When a rheumatologist says you should not be on steroids long term, what do we mean by long term? Hello, this is Dr. Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine, expert in rheumatology and regenerative medicine. Question that on occasion gets asked of me is, when I say you do not want to be on steroids long term, what do we mean by long term? And what do I mean by short term? Begin with autoimmune conditions. What are they? Your immune system meant to protect you from bacteria and viruses, in some people, can miscommunicate and start attacking your own body. That's an autoimmune condition. In an autoimmune condition, we don't have an easy on and off switch to turn that overreactivity off. There may be some mild versions of inflammation that may be limited in scope or intensity that can be managed with conservative options like diet and supplements. Most autoimmune conditions, certainly if you're coming to see me as a rheumatologist, you likely have something that has escalated that requires more aggressive management. Aggressive management of the immune system means to modulate and in some cases suppress the immune system. Back in the day, if you had an autoimmune condition, let's say something like rheumatoid arthritis, that was really strongly progressive and would very most likely lead to severe damage in the joints, severe pain, disability, earlier death, and really a miserable quality of life. In the early 1950s, physicians discovered that you could utilize cortisone or steroids to treat rheumatoid arthritis, and then progressively other autoimmune diseases as well. In those cases, they took people who were severely inflamed, severely disabled, and really quite impacted, and gave them a significant degree of quality of their life back. In that case, steroids were really life-changing. The problem is that steroids have a ton of long-term side effects. So short-term, if you're taking significant doses of steroids, you'll have an elevation of your blood sugar. It can lead to insomnia, irritability. It can lead to short-term issues like that. Long-term, and that can mean years, months, even weeks, it can start to affect your other aspects of your health. Higher blood sugar levels can lead to other metabolic issues, such as eventually diabetes, high blood pressure, higher rates of cardiovascular disease, dyslipidemia, meaning your cholesterol levels can be off, fatty liver. In addition, high doses of steroids suppressing your immune system can lead to higher rates of infection. On the metabolic level, it can lead to issues that are problematic in the bones, such as avascular necrosis, where you're actually damaging the blood vessels in the bone, leading to damage and destruction of the bone as well. So there's a lot of really bad things that can happen with long-term steroids. So how do I, as a rheumatologist, define long-term? So when we talk about long-term steroids, a lot of times it depends on what is the nature of the condition. We know that if you're on steroids for even a few weeks, you start to get some of these metabolic side effects. So as much as possible, we want to transition people away from steroids. As a rheumatologist, using steroids in your patient should always be something that you're doing for a limited period of time. And because of that, starting in the 1980s, rheumatologists have been utilizing disease-modifying treatments, other types of medications that modulate and occasionally immunosuppress the system, leading to reduction in steroid use, continued control of a person's autoimmune condition, and in most cases, well-tolerated treatments that can be utilized long-term to keep people in a low disease activity status, and in times even in a remission status, as long as they're on treatment. So when we're talking about long-term, it can depend on what the condition is realistically. Even though we know physiologically more than a couple of weeks or a few weeks of steroids can start to lead to longer-term problems, a lot of it depends on what's the condition that we're dealing with. If you have an inflammatory arthritis condition, let's say rheumatoid arthritis, psoriatic arthritis, you may be on steroids, let's say prednisone burst for a week, 2 weeks, and then tapering the dose. So hopefully you're off that within a few weeks. If you have, let's say, lupus, if you have severe life-threatening disease, or let's say vasculitis, inflammation of the blood vessels, and let's say you have severe inflammation affecting the kidneys, the heart, your brain, these can be life-threatening, not just in terms of your pain and uncomfortable, but where you could actually die. In those cases, sometimes people will be on steroids. Traditionally in the past, they could be on steroids for many months, even for more than a year. With some of the disease-modifying treatments that are utilized nowadays, that amount of time has been shrunk. But still, in those kind of severe life-threatening conditions, that person may be on steroids for a few months now. That's a long time. And rheumatologists partly tried to limit the side effects that people get from steroids by either utilizing other medications to protect the person's body. Let's say a person who's on high doses of steroids, they may take a medication to prevent osteoporosis to protect the bones, or they may be actively trying to taper the medication as fast as they can in a safe manner so that you don't develop those kind of long-term side effects. With all that said, here are a few principles that I would recommend as a patient, and certainly for physicians, that you should have when it comes to utilizing steroids for an autoimmune condition. Number one is make sure you're using it for the right indication. Okay, so what do I mean by that? Number one, you absolutely have to have a proper diagnosis before you start getting on steroids. There's risk with these medications, and if you're using them without a proper diagnosis, when you think about the benefit versus the risk, I get worried that you may be taking on too much risk. The other thing is that even if you have an autoimmune condition, you can have other problems that could be causing your symptoms. Common example, let's say you have rheumatoid arthritis, or let's say you have lupus and you have joint pain. Well, not all joint pain is necessarily from inflammation or your autoimmune condition. You could have joint pain because you have wear and tear arthritis, or you have tendinitis, or you may have another condition like your vitamin D might be low, or you may have low thyroid. Those other things can cause pains as well. Or you may even have just chronic damage from your autoimmune condition that isn't necessarily inflamed any longer, but still on occasion causes some discomfort. Those are not necessarily reasons to be put on steroids at that time if you have another reason for causing that pain. So you need to be accurate and correct about what's your actual indication for getting on steroids at that time. That may limit the number of times you're on steroids, the intensity of steroids that you're taking, or the duration of steroids that you're taking as well to help protect you. Principle number two is, if you're starting steroids, your rheumatologist should always be asking, what's the long-term plan? By that, I mean, let's say you have rheumatoid arthritis and your condition is flaring. Let's say you're already on a long-term regimen, but your condition keeps on flaring up. Well, then your physician, even if they're starting you on steroids short-term, they need to be asking, look, do we need to be altering your long-term regimen, either by adding something else on or by altering what you're doing long-term so that you're better controlled? Alternatively, let's say you have a short-term gap in treatment. Let's say your insurance has decided to deny your medication for a month, and that's why you're flaring. That actually happens, unfortunately, more often than it should in America, but it does happen. Well, you may be on steroids short-term, but your long-term plan is still okay. You just have to get through this insurance snafu. That is a common thing. Or another example might be, let's say you have a diagnosis that precludes you from being on some other long-term treatment. Let's say you have cancer and you're still underway with treatment and your condition, your autoimmune condition is flaring. Well, you may be on steroids for a few weeks, maybe even a couple months, until your cancer issue is somewhat better controlled or treated before you can consider longer-term treatment for your autoimmune condition again. This happens, let's say, if someone is starting chemotherapy for cancer, which can be immunosuppressive, that can actually control their immune system, and you may be pulling back their autoimmune treatment as their cancer treatment takes more of a primary sort of concern at that moment. Another one would be in women who are pregnant. There are some medications that you don't want to use in the setting of pregnancy. Some of this has changed over time. Now we know some medications are actually okay to take. Some of the immunosuppressant medications are actually low risk to take in the setting of pregnancy. And if someone has a severely active autoimmune issue, they may be taking some of those meds, but in some cases, that's not appropriate in them. And back in the past, we definitely would not be using some of those medications because there wasn't that data. In those cases, a person might be on a dose of steroids that is fluctuating to help control their condition. But in all of these cases, even if the long-term plan is a bit murky because there's some other medical issues that are ongoing, your physician should still be dynamically adapting to your situation to help control your condition and to give you some guidance so that while the long-term plan is still in flux, you're still actively being managed to help reduce the amount of steroids that you need to be on. Principle number 3 is that if you're starting steroids, your physician should also be thinking next step, which is how do we start tapering it? If you have a short-term flare-up of your, let's say, rheumatoid arthritis, you may be on steroids just for 1 or 2 weeks, and then there is no taper, you're just stopping the medication. You may have a more severely active condition, let's say lupus or vasculitis or some other severe manifestation of some other autoimmune issue, in which case you may be starting a higher dose of prednisone or steroids, and you may be on that for a few months. But your physician, again, should be dynamically managing this. And when safe and appropriate, if your condition's under control, they should be trying to taper the dosage so that you're on the least amount of steroids as possible. And the last thing is, I was hinting at this, but some conditions may require longer-term steroid usage. That may be if you have another medical condition that precludes you from taking the typical kind of disease-modifying treatments that would help get you off steroids, or you may just not be in a situation where you can fully start the longer-term treatment until some shorter-term issue is handled. Let's say you have surgery that's coming up, can't necessarily start the kind of disease-modifying treatments that we want because there may be some infection control issues there, or maybe your insurance is off and your physician has to figure out how to get you medication in the short term. Again, in all these cases, if the long-term situation is murky, your physician should try to be thinking about what are next steps to help reduce your steroids, but there may be cases where you're on a little bit more steroids than you want to be on longer term. But if you have some vision as to what the long-term guidance could be as you get over that short-term hump, then hopefully you can start to reduce your steroids longer term as well. So in that kind of case, my point here is that when we say long-term steroids, a lot of it depends on what is going on with you from a medical standpoint, from a life standpoint, what may affect your ability to get off of those kind of treatments quicker than you would normally, and what is your actual diagnosis. Ideally, short-term would mean just for a couple of weeks, but in some cases, it has to be longer than that in order to help protect your life and to help deal with some of the other medical issues that you may be dealing with as well. So to sum up, if you have an autoimmune issue, if you need to be on steroids, hopefully you're working with a good rheumatologist that can give you some sense of how long you'll be on steroids, how to bridge off that, how to taper off that, what are some of the other options to take to help get you off those steroids as well. And if you are on steroids for longer term, understand that there are some risks. Some of those can be mitigated. Some of them you just need to screen to see if you are developing any other issues. But in all cases, there are safe ways to manage steroids in autoimmune conditions, and hopefully you're using them for as short a period as possible. As usual, thank you for your time. If you have any other questions, please let us know. Until we connect again, this is Dr. Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Have a good day and live well. Thank you. Bye-bye.